So today we're talking about design as a new strategy for shaping global health. And we know that there's been some significant progress made over the years in global health. Child and maternal mortality rates have been coming down. And the life expectancy is also on the rise in many countries. So definitely lots of things to celebrate. As the Sustainable Development Goals have illustrated, there is still a lot of progress to be made. And there's growing interest in design as an approach to be able to look at the more harder to reach populations in some countries around the world and think about how can we perhaps better include those voices and understand what the needs and perceptions are. Now, I do want to preface that we're going to use the word design today, but in the introduction to this panel, you would have seen the word design thinking. And there's many words that we use for design thinking: design, human-centered design, social design, participatory design, and today our panelists will be talking about design encompassing all of these terms. So please join us in that all-encompassing, embracing definition of design. And I would like to get a sense of people in the room. So in terms of this notion of design as a strategy for shaping global health, some of us may be skeptics, some of us may be believers, some of us may be somewhere in the middle. And I'd like to just run a really quick experiment to see who we have in the room along that spectrum. So if you are an avid believer of design as a new strategy for shaping global health, could you please stand up?
What does it mean?
I'm going to save that for one of our panelists. Well, one of them is I'm curious. So if you're curious, put your hand up. No. If you're a believer, stand up. And if you're a skeptic, sit down. But maybe we do this all at the same time. So if you're believers have stood up. If you're curious, put your hand up. And if you're a skeptic, don't do anything. Okay, good. Okay. So we've got a really good range. That's who you're speaking to. All right. Okay. Great, so the structure for the session is that we'll spend a few minutes, each panelist will spend a few minutes sharing a story, and then we'll have a discussion up here before opening that up to you all. So, Jocelyn, would you like to kick it?
Great. Thanks so much, Ledia. So first I'm going to start with the definition of what is human-centered design. The question has already arisen, and I'm sure that many of you are wondering what it is that we're actually talking about. So instead of describing it in detail, we're going to show a 2-minute video, which does a better job than I could do explaining what human-centered design is all about.
Human-centered design is a creative approach to problem solving, one that starts with people and ends with innovative solutions tailored to meet their needs. When you understand the people you're trying to reach and then design from their perspective, not only will you arrive at unexpected answers, but you'll come up with ideas that they'll embrace. Human-centered design is both how you think and what you do with it. It's a process that consists of 3 phases: inspiration, ideation, and implementation. The inspiration phase is about learning on the fly, opening yourself up to creative possibilities, and trusting that as long as you remain grounded in the desires of the people you're designing for, your ideas will evolve into the right solution. In the ideation phase, you come up with lots of ideas. Some too crazy to work, some too crazy not to try, and you'll refine them, tossing out the bad and improving the good. Making things helps you learn, grow, and test your ideas. Building a simple prototype gets your idea tangible and gives you something to put right back into the hands of the folks you're designing for. Without their input, you won't know if your solution is on target or how to evolve your idea. Keep iterating, testing, and integrating feedback until you've got everything just right. During the implementation phase, you'll build partnerships, shore up your business model, and get your idea out into the world, which was always the goal in the first place. Anyone can practice human-centered design, and everyone benefits, because it gets us all to solutions that are adopted and embraced.
All right, so many of you still may have questions of what does this actually look like, and how does this apply to global health? So I'll share one example from our work from IDEO.org. So IDEO.org is a nonprofit design and innovation organization. We grew out of the design firm IDEO. And we've been around for the last 7 years, applying human-centered design to challenges related to poverty alleviation. Within our work, global health has been a major topic, and in particular, the issue of access to contraception for adolescent youth, especially across sub-Saharan Africa, has been a challenge that we've really taken on for the last 5 years or so. So one project that sits within this portfolio of work that we've done is work that we did with Mari Stopes in Kenya. Mari Stopes is a provider of reproductive health services and contraception, and for decades has been exceptionally effective in reaching mothers for birth spacing and family planning. But they saw that they weren't reaching young adolescent girls, and teenage pregnancy rates, unintended pregnancy rates amongst young girls were continuing to rise across Kenya. So Mari Stopes came to us and said, how might we increase uptake of modern contraception amongst 15 to 19-year-old girls? And how might we integrate those solutions with their partners, their boyfriends, their husbands? So we started a human-centered design process that initially was several months in length and has ultimately extended to about a 2.5-year partnership that we've had with Mari Stopes. That started by spending time with those adolescent girls, with their boyfriends, their teachers, people that were inspiring to them, their parents, community leaders, religious leaders, to really get an understanding of what were some of these challenges related to access to reproductive health and cultural stigmas associated with premarital sex. And one of the things that we found was that going into the clinics was a really daunting experience for these young girls. The clinics were very bare in the way that they showed up, and the information that they got was filled with jargon and really technical and not very accessible to the young girls. Even when they were able to meet with a provider and sort of muster up the courage in order to go into the clinic, oftentimes that healthcare provider would ask them how old they were, ask them if they were married, and if the girl said she was 15 and unmarried, the provider would say, well, you shouldn't be having sex anyway. Here's a couple condoms, get out of here. So of course, this didn't really lead to much trust in the system, and no one was referring their friends to go into these clinics. And so what we decided to do was actually to create a lifestyle brand that was ultimately called Future Fab, which was really about helping young girls and their partners imagine and see the possibilities for what their future could be. And through that conversation then, they were able to get into a conversation related to what they were hoping for in terms of having children, completing education, and ultimately this led to information around contraception and access to those reproductive health services. So what we actually designed within this system was a whole series of things. We designed a system which included this lifestyle brand and a campaign around it called Future Fab. We designed radio shows that would promote Future Fab and tell stories about young girls and boys. We designed events, fashion shows, and talent shows where young people could come and showcase their skills and talk about their dreams. We designed a program for peer connectors, youth that would go out and talk to other youth about reproductive health and encourage them to come into the clinic. We designed the actual clinics themselves, really colorful, beautiful spaces where their girls would feel more comfortable, and new information that would be available to girls to help them make decisions about the trade-offs between different types of contraception, but framed in a really positive and simple way. And we designed training materials for the providers themselves to really start to remove some of this bias and judgment against the girls and to welcome them and serve them in a really different way. And then finally, we designed a very robust business model to ensure that the cost per girl served would not be radically different from what Mari Stopes was doing currently as they were serving women. And through this, what we found is that Mari Stopes was able to implement this solution now in 22 clinics across Kenya. And what they've seen is a 7-fold increase in the number of girls that have come in for reproductive health services and contraception. So what that's looked like is that in each of these 22 centers, the centers were previously seeing about 3 girls a week, and now they're seeing about 21 girls per week. So really dramatic increase as a result of really being thoughtful, designing with and for the girls and the people around them, and designing a solution that was really much more delightful and lovely and beautiful and engaging for these young girls to participate in.
Thank you, Jocelyn. That's
Thanks.
a really powerful story. Dave, do you have something that you want to share with the group?
Yeah, so bear with me if you can't tell from my outfit up here. I'm the bureaucrat, so this might be a little slow. So I'm acting director of the Center for Innovation and Impact. We're a relatively small team within the Global Health Bureau at USAID. And a lot of our work is working with young entrepreneurs and helping them through this journey of developing from an idea of a global health innovation and getting that to scale. And one of the real needs that we've seen through this work is around better understanding the user. And we've found that human-centered design is a great way to sort of complement that more traditional product development process and bringing in that user understanding earlier on in the process. USAID has been operating for decades. In fact, it was founded during the Kennedy administration and have been using the principles of human-centered design for decades and in great ways. And so over the last 3 years, we've been more deliberately applying human-centered design through a partnership that we have with Dahlberg Design. And over the course of these 3 years, we've worked on, I think, over 10 projects in multiple countries across many different health areas. One example is chlorhexidine, which is a low-cost antiseptic that you can place on the umbilical cord at the time of birth. And it's been shown to reduce mortality in newborns by somewhere between 20 and 40%. But in a place like northern Nigeria, women are oftentimes using things like methylated spirits. In some instances, they'll use cow dung. And the approach is to really make this umbilical cord fall off soon, because to them, that's a healthy baby, and they will have a burial ceremony with the umbilical cord. And what we found is that the manufacturers in Nigeria were sort of going towards these mothers and families with more traditional health campaigns about the clinical efficacy of chlorhexidine. And so working with the design team at Dahlberg, we did a lot of sort of understanding of perceptions, incentives, and worked with all the stakeholders in Nigeria to really co-develop effective marketing campaigns. And so we'll talk a little bit later about how that has played one part in helping to scale up the use of chlorhexidine in Nigeria. But I'll also mention another product that we've worked on. So through our Fighting Ebola Grand Challenge Fund, a couple of different innovators around developing new personal protective equipment. These were often teams based in the US that did a lot of work to understand what healthcare workers in West Africa needed during the outbreak. And so with Dahlberg Design, again, we went in country with these teams. In this case, it was Sierra Leone, and really went through this co-design process with healthcare workers themselves. And I'm happy to say that the WHO just last week, and I think Mei Chu is here, who really helped get that over the finish line, has sort of launched new PPC, which are preferred product characteristics for new personal protective equipment based on a lot of this work that came through that process. So we've seen the effectiveness in both sort of products, but also interventions and campaigns. So we're excited to sort of share some of that today, and I'm certainly a big believer, and hopefully can turn some of you skeptics into believers as well.
Thanks, Dave. We're really excited to hear more about that a bit later on. Tracy, do you want to take it away?
Sure. So I sit on a team within the Bill and Melinda Gates Foundation that's called Integrated Delivery, and we do everything from sort of design and develop to launch new products and services. Since we've had two great examples of how human-centered design can play out across a complex system that involves products and services together, and Dave has given some really good examples of product development, I thought it might be good to share a story about how design has sort of helped us within the foundation reframe some of the things that we look at and sort of changed a little bit the way that we work. So several years ago, I was sitting in a convening that was brought together by the nutrition, maternal and child health, as well as pneumonia teams at the foundation. And clinician after clinician got up to talk, and we were specifically looking at the idea of under 5 morbidity and mortality. And clinician after clinician got up and shared stories of seeing children under 5 present to a facility with an upper respiratory tract infection or something related to diarrhea. And that they would stabilize these children, send them home, and find out within a day or two that the child that they thought they had sent home on the road to recovery had actually died. And so we began to realize that we needed to understand risk and therefore vulnerability from a wider, sort of take a wider aperture on that. We're often very clinically and biologically focused. And so we started to think about how might we examine social vulnerability? How might we really expand that category of vulnerability? So we started a project in Bihar State in India, which is one of the sort of most under-resourced, poorest, and most populous states. And we were working in a number of districts with families who had children under 5 who had either passed away or had been sick repeatedly, as well as those families where, against all odds, children had survived and actually thrived. And we were working with a Delhi and Bihar-based design team that also included a number of anthropologists. And we started looking, they went into these houses, spent a lot of time with these families, and they were sort of a little bit confused about how it was that these families were categorizing space in and outside of the home. So they would come back and tell me stories about how if a child was inside the house and actually picked up some dirt from the ground and ate it, that wasn't really remarked upon, or it wasn't a behavior that was carefully monitored and stopped. Once outside the family compound, if a child did the same thing, then it became behavior that they needed to change and respond to. And the team was trying to figure out, how do we understand this? How do we understand how families are sort of categorizing space vis-a-vis safety, what's safe and what's not safe? And so as we talked about it, we actually turned to anthropology and started looking at that literature. And one of the things that we know from that field is that dirt is actually matter out of place. So your dirt is not the same as my dirt. Because often what it is that it's something to us that doesn't fit where it should. And so when we started to think about it that way, the team went back into these households, and they were able to look at the households from the vantage point of the families themselves and start to recognize that families actually were doing things to try to mark off safe spaces. And so around the hearth or the chula, around where they kept animals, you could start to see in some houses that there were these sort of intricate sort of patterns on the ground out of colored sand. We went into families where the children were actually thriving, and we could see that in those families, important things were often hung. There was some way to sort of elevate them off the ground. And so what the designers started to do is use those, what we call affordances, use what we were learning from the community about the way that they tried to ensure safety, and expand them out to encompass the safety of their children. And so little by little, you could see families making these same markings around the areas where children were laid to sleep during the day. And so we used the behaviors of people themselves and adapted them a little bit so that they were encompassing those issues of safety that we were looking for. And what that also did, so that's sort of what was happening in the field, so to speak. And what we actually came out of and is being piloted right now is actually a healthy homes blueprint. So how it is that a frontline health worker could go into a home and help them begin to make a more safe space for them and their families. But what it also did is it allowed us within the Gates Foundation to sort of realize there are other ways to reframe problems, and that's one of the values of human-centered design in so many ways, is that it gives you different vantage points and different disciplines from which to look at a problem. And when you look at a problem from a different perspective, you begin to see different ways to solve that problem that maybe you hadn't thought of previously.
Great. Thank you for giving us that different angle on how design can be applied. So zooming out a little bit from that example, why do you think now is the moment for designing global health, Tracy?
I think it's three things, actually. And the first is that we know that design has been being used in the private sector for quite a while. And in 2015 or 2016, a design value index was published, and it tracked 16 companies that used, very intentionally, relied on design within their corporate strategy. And that's Target, Apple, Costco, Starbucks, you can think of others. But they looked at these 16 companies that were using design and compared them against the sort of traditionally traded companies on the S&P 500. And what they saw was that these companies that had intentionally integrated design into corporate strategy were outperforming their competitors by 211%. So we can clearly see that in the private sector, gains are being made and made strongly through design. I think the second issue is, Ledia had mentioned the SDGs. And in 2015, the United Nations came out with these sustainable development goals. And they're audacious. I mean, it's no hunger, zero poverty, full gender equality. And they're going to be hard to reach by 2030, which is when we're hoping to achieve them. And so what you start to see is that there's an expanding sort of array of issues that donors and funders can put their money toward. And so we're finding that as we're trying to solve so many problems across the world, we're having to do more with less. I think that feeds into the third issue, which is, as a field, global health and development has started to take more of an equity lens. So we're realizing that consistently there's about 20% of the population that we're just not reaching. And one of the adolescent girls from Jocelyn's story, they often fall into that 20%. And so there's a strong sense that the way we've been working, which is very much from a supply side. You know, if we make sure that there is access to efficient and affordable health solutions, that will make a difference. And I think what we're starting to realize is the supply is really important. That access is really, really critical. But we have to do more to understand how we can better empower and enable people to really to actually access that supply of solutions. So I would say it's those three things coming together that I think has been the real impetus for why there is so much interest in design in global health.
Yeah, great. And Jocelyn, you shared a wonderful story with Mary Stopes. I'd love to hear more about what else you've seen in the work that you've done over the last 7 years in terms of how design has led to better outcomes, better practices, and if you could share some thoughts on that.
Yeah, I mean, I think we've learned so much in the last 10 or 12 years with IDEO and IDEO.org practicing or applying human-centered design to challenges related to poverty alleviation. I think some of those things are, we really started, and one of the things when we started doing this work was sort of overemphasizing perhaps the value of fresh eyes. And I think we thought that, designers sort of going in with little familiarity of a context would sort of be best placed to be able to address these really complex challenges and cultures quite distant from our own. And I think what we've learned over the last 10 years is that, well, to a certain extent, fresh eyes are really effective and really do lead to great creativity and solutions that others perhaps have not considered. It's equally important that we build expertise and build connections and stronger partnerships and bring in people that have background and experience, both working in the social sector, being from or working with the communities in which we're working, and really having some depth of expertise in some of these sectors in which we're working. And so I think that's been a major shift that we've really seen over the last 10 years. I think the second one that I would mention is that, initially, and I think because of the market for human-centered design, which was really nascent 10 years ago, the projects that we were able to do were quite short. And so when we were handing over solutions to nonprofit organizations and hoping that they would be able to implement them and scale them up with little additional support beyond that first 2 or 3 months of work, we found that it was really challenging, very hit or miss. Now, so much of our work is done in a programmatic way, where we have the opportunity to work with partners over the course of 9 months or 3 years. And there we're able to really work on not just the early design research and the concept development, but we're able to build and run live prototypes and pilots, support implementation, and then continue to refine these solutions for scale up.
Great, okay. And Dave, I've got a question for you as well. I guess a lot of the times people ask about how does design help with scale? Do you have any thoughts on that?
Yeah, it's the silver bullet. Just kidding. It's the only thing missing. No, traditionally in global health, it takes 30 to 40 years for a product or intervention to reach some sort of scale. That's a really long time. And the reason that it takes that long is it's a really complicated, complex process. These are challenging markets with really insufficient healthcare infrastructure. And on top of that, there's so many different stakeholders that need to be working together to accelerate access to these products, from folks in government to procurers to supply chain folks to the user themselves to their families. And what we've seen is human-centered design can be a great tool and process and mindset to take into account all of those perspectives. And so for the example of chlorhexidine in Nigeria, while our work was focused on sort of new ways to generate demand and change behavior, it had to fit into an overall sort of national strategy for scaling up chlorhexidine there. And we're happy to report that in 25 states now in Nigeria, they're procuring chlorhexidine and using a lot of those principles that we developed in partnership with governments and other folks in Nigeria to really help accelerate progress.
Can I add something to that? I completely agree with everything Dave has said, as always, but I think the other thing, though, that is a tension with design and the idea of scale is design is brought in as an innovative method, so it's all about innovation. And really there's a tension between innovation and design, because design and innovation is partially about trying new things and being willing to fail in that process, because you know that you learn from failure. I mean, as you saw in the video, we want to de-risk situations. We want to actually start to ideate on solutions, make them into prototypes, put them into people's hands, and see, do they work or not, rather than go through the process that with an idea that we haven't really tested with people, take it all the way through the process Dave is talking about, and perhaps get to the end and realize, we didn't anticipate something and this isn't working. So there is this tension and trying to understand that innovation also means failing and learning, whereas scale means taking something you are pretty certain is going to work and building it out from there. And so how do we reconcile that tension a little bit more and allow ourselves to fail a bit as we learn, and not always bring scale in from the very beginning of the conversation, but bringing it in at the right points when it's ready.
Well said.
Great. Before we open it up for the audience, and I'm sure there's some questions that are reeling, I have one more question for you all. So what's next? We've talked about what we've learned and some of the things that have come up as we've experimented with design in the last few years. What's next and where to from here?
So I'll start. It was probably last summer when you and I first started talking. And we were thinking about the fact that design was no longer in its infancy, or design in global health was no longer in its infancy phase. We'd moved beyond, hey, there's this new way of working, you gotta try it, to really more targeted and focused questions, sort of, what's the right dose of design? When do I bring it into the process? What should I expect out of it? What is a prototype, and how do you evaluate prototypes? And so the questions were becoming more sophisticated, and I started to realize, but they were also, it was interesting, in my position, I work with other donors, obviously, with implementing partners, with design firms, and so on. And it was interesting that these questions were, the same questions were coming as we were going through this journey from all the different sides. And so I started to think, we're actually in sort of our adolescent phase. And for those of you who have 13-year-olds at home like I do, it's not always a great phase. And so how are we going to get them? Right. How am I going to get, the 13-year-old to 17 years old without one of us giving up? And so, so we decided that it might be a good idea to bring together representatives from these three different communities: donors / funders, implementing partners, and design groups. And so bring them together, and we brought them together at something we called HCD Uncut in Berlin. And we talked through all of these issues. Where are we as a field? What are we really struggling with? What do we need to do in order to do design better? And make sure that it's not something that people look back on as, oh, that was sort of a flash in the pan. And so we had this convening. I think I was a little bit surprised at the extent to which we were still sort of saying, what is it? The question that someone from the audience started us out with today. What really is it? And so we decided that we wanted to put some resources out into the world that would help people answer those questions a little bit more. And why don't I pass that part to you?
Yeah, and I think so at that convening, it became really clear, and there was a consensus that, as a community, that we could really accelerate the more appropriate use and effective use of human-centered design in global health, and that there was a real opportunity for us to work together as donors, but also with designers and implementing partners to really map out what it will take to reach that point where we move from sort of these one-off projects to more mainstreaming it, really going from retail to wholesale, as they say, with human-centered design. And so as part of that process, we've been working with Sonder Design Collective and Dahlberg Design to help facilitate and work with all the partners that were at HCD Uncut to develop a set of tools to answer some of these questions about what is it, to help donors, implementers, designers to better understand how and when to embed this kind of thinking into our collective work. And then also sort of lay out an investment roadmap that we as a community and community of practice could work towards, things like developing evidence around human-centered design, things like defining what it means, things like capturing and sharing best practices. And so with the Herculean effort of one Pragya Mishra, can you stand up, Pragya? And you'll understand why we're clapping here in a minute. Along with my colleague Nikki Tyler, Rachel Fowler, many other folks, have developed what's called, if you can pull up that screen, designforhealth.org, which is a resource library and a growing library of tools to help us down that journey around how can we better implement design in global health. It has a set of tools and resources, and we're officially launching it today, so we hope that all of you will both get in there and test these tools. There's ways to provide feedback, and also join this sort of movement and this community of practice so that we can more quickly get to a point where we're applying human-centered design and really accelerating progress against these SDGs.
Thank you for that. So we've had a launch. Let's have some questions. You know how this rolls. You've been here a couple of days already. Please put your hand up and a mic will come to you. State who you are, what your question is, and who you're directing your question to. So let's start with the lady in the middle there.
Thank you. My name is Sibel Bjorklund, and I have, it seems like a rote question, but it strikes me that sometimes it might be really clear which humans you're designing for, like the teenage girls in Kenya. But what about when you have a challenge and there's sort of two sets of people? How do you reconcile who your design focus is? Because I can say the end user, and in a very American sense, I could think of a surgery unit at a hospital, and the end user, I suppose, is the patient, but the people who are driving it are the clinicians. So if you were approaching human-centered design to something like that, who would you design around? You have to design around both, but who takes primacy?
Are you directing your question to anyone in particular?
Anybody's
Can I try? Can I jump in?
Yeah, sure. So I can just talk about that briefly with some work that we did in Ethiopia for a program called Adolescence 360 that we were working on with PSI. And there we were designing for, again, the increase in uptake of modern contraception amongst young women. But what we realized pretty quickly was that the highest need in Ethiopia was rural young married women. So in rural Ethiopia, women were getting married at a very young age, between 14 and 16 years old oftentimes. And their bodies just weren't ready to be pregnant and to deliver children at that age. And so we realized that we needed a strategy that was going to work for the women, but also their husbands were such important players in the design of the solution. And if we were going to reach rural Ethiopia, Ethiopia is not a country that has tons of nonprofit organizations with community health workers all around. Really, the health services are being delivered by the Ministry of Health and the community health workers that go from the ministry. And so there we needed to design for sort of three big players. The first was the woman, the second was her husband, and the third was the community health worker. And so there we did a lot of things in terms of as a way to engage husbands, because they didn't want to spend their time talking about contraception with the community health worker, but we said instead, we're offering you a free financial planning session. And so the community health worker, we designed a curriculum for her to actually be able to talk about with the family about what their hopes were for the future. And they would talk about things like wanting a larger house, or ultimately having 3 or 4 children, being able to send their children through secondary school. And through that financial planning exercise, they were able to talk about family planning and family size and when they wanted to start having children, and from there to talk about contraception. And then along with that, it was really designing everything from, one of the elements we designed was the backpacks for the community health workers, so that they could really easily carry the contraception that they needed and the information about it, and training materials that were not reliant on high levels of literacy, but were very visual and very simple in what they delivered. So that's sort of the way that we think about how we design in these systems for these multiple stakeholders.
Great, thanks for that.
Can I
I'm going
add
to I'm going to go for a couple more questions. Just, so can we have, yes, I think there's a lady there and there's a man at the back there. We can get, yes.
Great. My name is Phyllis, and I'm with UBS Optimist Foundation. And it sounds like human-centered design is a great way to look at solving problems at the, I'll say, the retail level. What if we're looking at problems that aren't necessarily trying to sell an Apple computer or trying to get somebody into a healthcare clinic, but more broadly around trying to change behavior overall to get people to do something they wouldn't have otherwise done? Is there...
Thanks, Phyllis. We'll get one more question and then we'll, so there was a gentleman at the back there.
Yes, hi, I'm Chris Redlick from Stanford Healthcare. Are there any people in the United States using design to deal with some of the macro issues of better design of delivery with the implication of improving cost structure?
Okay, so Tracy, do you want to answer the first one?
Sure.
And then...
So that's a great question, Phyllis. One of the things, and we've all talked about this, and within global health, you don't often talk about behavior change, or when you do talk about behavior change, it's sort of behavior change communication, or it's sort of put in its own silo. But one of the things that we've tried to help people understand is that actually anytime you put a product or a service into the world, you're actually asking people to change their behavior, because you're asking them to stop doing what they were doing with the product or service that they were using initially and take up this new one. So everything really involves behavior change. But thinking about it sort of on the wholesale level, Jocelyn mentioned a project like this. We've also at the foundation been funding the redesign of the labor ward. So that the space where women go to give birth. In global health, we want people to go to facilities. We're driving pregnant women there to give birth in facilities. But oftentimes, they're not a place people want to go. And so what we did was with this a partner, a design firm based in Helsinki, M4AD, we looked at the labor ward experience. What is it like for a woman when she goes to the facility with her family, with her partner, whomever it is she brings with them? What is the experience she's having? What's the experience we want her to have? How do we design that experience both through services, the products that support those services, as well as actually the architectural layout of the space? Now, in certain situations, that does become very context specific, because what that space might look like in Patna in Bihar, India, is going to be different from what it might look like in Abuja, Nigeria. But what we've been able to do is sort of take that model and almost use it as a diagnostic, so that when we go into new places, it's not about learning from the very start, but it's actually about using that model as a diagnostic. We know these are the critical touch points in the journey that we're going to want to make sure the best behavior, the best sort of progress is happening. And then we're much farther into the process as our starting point. And so we can adapt more quickly and then design those labor wards to fit that model in the context-specific way necessary.
Great.
Yeah, and just quickly, another example. It's not always just about how do we get a new product or service to be used. So we're now looking at USAID about using human-centered design to help the youth of Africa define their own future. There's a huge youth bulge coming in Africa. The median age in Mali is 15. Come up to me afterwards. I have a joke about Mali that I'll tell you. But what we can do is use human-centered design as an agency and other donors to understand how do the youth of Africa want their future to be, or what do they want it to be? And then that can inform our programming, so we can look at things like grand challenges or informing our missions that are around sub-Saharan Africa and how they should be meeting those needs. So it's not always just about getting a product or service in, it can also help shape strategy as well.
Yeah. So then really quickly on the other question, many design firms have major portfolios in terms of health work that includes IDEO and other design firms. Our focus here is really on global health, so we don't tackle those issues as much. But I would say certainly look to some of the for-profit design firms.
Great. Thank you. We have time for one more question. I'm going to have to go to this side of the room because I think I've been a bit unfair here. So yes, we've got a question and a mic ready to go.
So,
Two questions. We'll have another one here, and then
so
very quick answer.
very helpful. I just want to make sure I understand how this design thing works. What I hear you all saying is it's an effort to really figure out what the users might want, and then base an awful lot of what you do on that information. And I'm just sort of a little puzzled about how different is that? How do you see it as being different than what, for example, big businesses do when they try to figure out if there's demand out there for a potential product? I just want to understand the nuance of it a little bit.
Okay, so how is it different? And we've got a question up the front here, if we can quickly squeeze that in as well. Very eager man here.
Ledia, take that one.
Thank you so much, Jocelyn and the panel. I'm Mohammad Sabir from Pakistan, and I want to take this human-centered design to the people who are like don't fit into social consciousness of society. Like I'm talking about my community who are gypsies and nomads. So mostly they're living in a wilderness or in their own, moving in their own gypsy routes. So how can we bring these human-centered design to bring health and education to there? Because I believe that is their basic human right. And these things, when I hear conversation about this, these are just about the people who are living in settlements or like in houses. But my community also deserves this. And how can we partner? And how can, do you have such program for the communities? Like nomadic and like, yeah. And second thing is that, why these sort of things are not happening in third world countries? Because it is more accessible to a larger organization and a larger population. And like a country like Pakistan, where these things are very valuable and due to security and things. And my community, which is just very bottom of the pyramids, they don't show up. So how can we bring it over there? Thank you.
Thank you, Mohammed. So very quickly.
Why don't you take
Why
that
you
first
take
one?
the first one?
Yeah.
How is it different? Okay, design to me is a bit of a research translation function. As much as it is design in its own right, there's a lot of academic literature in global health that people on the ground who are trying to implement programs maybe don't find as accessible. And so to me, it's this way of bringing some of that research and translating that and bringing different perspectives in. So it becomes a complementary approach. It's not here to replace anything. It's about working with anthropologists, sociologists, clinicians, citizens, and really bringing together and understanding problems from these different vantage points, taking a systems view to do that, rather than living in sometimes some of these silos, and having this ongoing conversation day to day and throughout from defining the problem through to implementation, doing that as a group and co-designing what that looks like, rather than living in our bubbles, which we often do. So that's my perspective.
Yeah, I mean, I would also just add, design thinking and human-centered design have been practiced in the private sector for the past 30 years. So this is a construct that draws from both what's happened in terms of participatory research and participatory design from the nonprofit field, combined with what's happened in the for-profit world. And what we're seeing here is a culmination of those things together.
Mm-hmm. Can I, so Mohammed, thank you for your question. Just quickly, the social vulnerability project that I talked about in Bihar State is actually intended to reach this very marginalized population that usually we don't reach. And so one of the values that we do believe design brings to global health is actually reaching some of those much harder to reach populations and spending the time with them to learn from them, but also bring them along in terms of development of their own solutions. At the same time, I mean, within the foundation, we've made a commitment to try to ensure that we are supporting the development of designers in the communities where we work. That hasn't as yet extended to how could we train people themselves and sort of using design and the thinking it affords to respond to problems on their own. I could see it going there, and there are some groups that do that. But we're at least trying to really sort of bring in the population, the design community in those populations we're working with to build up that capacity and ensure that they are part of the teams and they're actually going out and working with these harder to reach populations.
Great. Thank you. I've been told we're out of time. I know we have not answered all your questions, but we'd encourage you to come forward and we'd love to have a chat to all of you.